Welcome, everybody. It's fantastic to see all of you here. This is one of our highlight lectures of the Koch Institute year, so it's really my honor to welcome everybody for the Judith and Lippard Memorial Lecture, which of course is an opportunity to honor the life of Judith and Lippard and a chance for all of us to come together and learn about cutting edge research related to a topic relevant to women's cancers. I want to extend a special welcome today to Judy's son Josh, who is here with us today. We're very happy that you were able to make it. I also want to say that unfortunately Steve Lippard and Josh's brother Alex, who have been able to come in the past and wanted to be here, are unable to be with us this year, but nonetheless we miss them. The Judith Ann Lippard Memorial Lecture was established in 2014. This was, of course, in memory of Judy Lippard, who was Steve Lippard's wife. Steve Lippard is the Arthur Amos Noyes Professor in Chemistry at MIT. Judy was beloved by many in the MIT community, especially students, where she offered endless support over the years. Many of you know that Judy passed away from endometrial cancer in September of 2013, and in her memory, Steve, as well as Josh and Alex, came together, along with countless family, friends, students, colleagues, to create this lecture series to honor Judy's memory and celebrate her generosity and remarkable life. The goal of this lecture from its inception has really been sort of reflective of what we do here at the Koch Institute. The idea is to bring together people who are coming from biology, chemistry, engineering, clinical medicine, really anything that we can bring a multidisciplinary approach to bear on better understanding challenges of cancer that face women. And it also is an opportunity for us to interact more with one of our local cancer centers in town, the MGH Cancer Center, and bring in, most importantly, a remarkable speaker. This year, we're very excited to have Dr. Becky Stone, who many of you know, to be here to deliver the 9th annual Lippard Lecture. So about Becky, she's for many of you, needs no introduction, but if you do not know her, she's an associate professor and director of gynecologic oncology at Johns Hopkins. She also holds an appointment in the Armstrong Institute at Johns Hopkins and is the lead for the Surgical Pathways Enhanced Recovery After Surgery program there. She also serves as the co-director of the Fertility Preservation Center, and she's pioneered novel surgical interventions to help people fulfill their goal of parenthood in the face of cancer. Becky's been recognized for her dedication to patient care and teaching. She was named Physician of the Year at Johns Hopkins in 2023, which I can assure you is an incredible accomplishment. She's being inducted into the School of Medicine Distinguished Teaching Society. That occurred in 2022. She's committing to ensuring that ovarian cancer preservation becomes a well-known standard, ovarian cancer prevention is a standard of care. I think we'll hear a bit about that here during her talk today. And she's led an international task force that's really trying to improve outcomes and really lower the burden of ovarian cancer. I know Becky quite well because she's very close to one of my close friends and colleagues, Angie Belcher, who sadly is doing important work in DC and so is not here today. But Angie, believe me, probably talked to me for 3 hours about what should she do, how should she approach this. But regardless, Becky collaborates with many here, of course, Angie Belcher, but also Sangeeta, Paula, members of the Breakthrough Cancer Ovarian Cancer team. And with Becky's help, she's really instrumental to much of the work here on ovarian cancer and making great headway in how we can better detect and prevent that terrible disease. The title of her talk today is The Science Fiction of Ovarian Cancer, What We Got Wrong and Why It Matters. I'm really excited to have you here. Becky, thank you so much for accepting the invitation. We all look forward to your talk.
Gosh, that was really just a lovely introduction, and I am incredibly humbled by that. Thank you. And, thank you for having me. This is a tremendous honor, to the Lippard family and to Dr. Vanderheiden and many of you who I have come to know over the last couple years. Working with you on much of which is related to breakthrough cancer has really been one of the greatest highlights and joys of my life. I have learned so much from you guys. You have changed the way that I think and how I feel about science, and I'm very grateful. Judith passed away from endometrial cancer, which is a cancer that I commonly treat now 11 years ago. And I'm talking about ovarian cancer, so hopefully that's okay. But I think it is because the two are really very importantly connected by one anatomic structure that no one really ever cared about until recently, called the fallopian tube. And, for decades, we believed that ovarian cancer started in the ovary, because where else would it come from? It's called ovarian cancer. But as it turns out, this story is probably more science fiction, so to speak, than scientific fact. And in order to really know the truth, we have to think about the gynecologic organs in total. And the truth is that ovarian cancer is one of the biggest blind spots in the history of medicine that has affected women. There are a couple other important truths. It's not that uncommon. A person is diagnosed with ovarian cancer in this country every 40 minutes. Try as we might, and many, many billions of dollars, screening really has been categorically ineffective. We have not been able to successfully develop it. And it is a devastating, often lethal disease. And by devastating, I mean suffering and desperation and loss and grief from the minute someone with this cancer walks through your clinic door. Not just for you as their doctor, but for the patient, their family, all the people that loved them. And that is the truth, and that is fact. This was actually the headline in the Wall Street Journal 20 years ago. And it really called attention to the fact that ovarian cancer has long been a disheartening outlier in progress made towards reducing the global burden of cancer. And unfortunately, this really remains very much the same today. I mean, this red line, maybe it's at 51 or 52%, but at the same time, that blue line has gone up, quite a bit. And so ovarian cancer really still lags behind quite a bit. And so when we think about sort of what's going on in the research space of ovarian cancer, and this is something that that Josh's dad was very familiar with, because he did so much work in this space for ovarian cancer, and really was one of the people that defined the backbone of chemotherapy that we use today in terms of platinum therapy. I was just at our annual SGO meeting in Seattle a couple weeks ago, and was just sitting in the audience, sort of seeing hour after hour of data like this presented, where really, the celebration or the win is about, a couple months increase in progression-free survival, right? So here, this is a trial that's going on called DUO-00, which is a trial to treat people who are diagnosed with with a new diagnosis of ovarian cancer, advanced ovarian cancer, and it's comparing platinum, and Taxol with a drug called bevacizumab to something that has 5 drugs, including immunotherapy and a PARP inhibitor. And we're super excited because people now they have 5 more months in remission, so 2 years instead of a year and a half. This is the newest drug, one of the newest drugs, most exciting drugs that we have to treat platinum-resistant ovarian cancer. And we're very excited about survival curves that look like this, where we're talking about 3-4 months versus 5 to 6 months. And every single woman who has platinum-resistant ovarian cancer dies of that disease. And so, I'm sitting there in the audience thinking like, gosh, this is just so painful. And I take care of these people and, literally sitting there in clinic showing them these survival curves, right? I mean, they just look at you like you're crazy, like you're talking about 3 months. I think like, well, what if we could take this from like months to years, or like, how about never? How about never getting ovarian cancer? And all the inhumanities that people suffer from when they get this disease, all the billions of dollars that we spend on developing therapies to treat a disease that people die from. What if we could do something that costs almost $0, in some cases $0, or a couple $100? And that's really what I want to talk to you guys about today. So, prevention, right? When there's no screening, when the vast majority of people walk through the door with very advanced disease, and while treatments help, and I certainly don't want to disparage that, it's a very important area of research and work and time, and it's time, to give someone back time that was never in their cards is a wonderful, miraculous thing to do. It's one of the reasons I'm an oncologist, but it's not. It doesn't save many people, and so to me, when I think about what is hope, it's that that someone never gets this disease. So I want to just tell you a story, and I think those of you who I was here about 2 years ago, and we were sort of on the front end of this story. You all have contributed to how I have thought about this story, how this story has evolved over the last couple of years. But this is a story that really started in the mid-90s, right? We knew in the mid-90s that there were these families where every generation had a number of women that were affected by breast and ovarian cancer. And then, we figured out how to sequence DNA, which was an amazing discovery. And in doing that, we were able to figure out, medicine science was able to figure out that there were these hereditary gene mutations, right? That were passed on from generation to generation that were responsible for breast and ovarian cancer in these families. And these genes are called BRCA, right? BRCA1 and 2, even though they have the same name, they're completely unrelated and they do very different things. And so importantly then, people thought, everybody was just as frustrated with this disease then as we are today. They thought, okay, well, we can now do genetic testing, gene sequencing, to identify who these people are that have a high risk of ovarian cancer. And we can prevent the disease by removing their ovaries between the ages of 35 and 45, because these women get ovarian cancer much younger than the average age of the mid-60s. And that's great. And so that became standard of care in the early 2000s. The thing of it is, though, is that genetic testing has been around for a while, and yet many people for whom genetic testing is indicated, for whom it's recommended, don't have it done. For instance, on the left, that's basically showing you that only about 6% of people, of women who have had breast cancer and who have a first-degree relative with ovarian cancer, actually have genetic testing. And then on the right is basically showing you the percentage of people, about 30%, who have what's called cascade testing, meaning that they have a family member who is test positive for a gene mutation for BRCA or other genes related to high risk for ovarian cancer. And knowing that their family member has this gene and that there's a 50% chance that they would have it, they do not go through with cascade testing. And there's a number of reasons for that, and not the point of the lecture today, but I show you this because, yes, it's all great and fine, but we have to be able to identify high-risk women in order to offer them an intervention, which we have always recommended ovarian removal. But there's like a dark side to ovarian removal, and we've only just begun to really learn about this. Like when you think about risk-reducing surgery, right? This came of age in the early 2000s, and we're in 2025. And so we are just now beginning to understand the impact of removing ovaries from very young women, and in many cases, not giving them any hormone replacement because we were very afraid that they would increase their already infinitesimally high risk of breast cancer. And so, when you take the ovaries out, right, you lose ovarian hormone function. These women go through early onset menopause that is terrible. And it has real long-term health risks in terms of bone density, and increased risk of dementia and glaucoma, cardiac risk, so on and so forth. And so what has happened is during this 25 years of the evolution of risk-reducing surgery for like the BRCA community, women have become increasingly fearful of risk-reducing surgery because they can't find a doctor who will prescribe them hormone replacement therapy. And so you can see, and I don't know if you can see this, but in this table here, it's basically, sort of like a nice summary table just showing that if you look across these studies, contemporary studies of women undergoing risk-reducing removal of the ovaries for ovarian cancer prevention, and they have a BRCA1 and 2 mutation, that first of all, a large number of women don't have the intervention, and many of them are delayed to the intervention. So, typically we recommend for BRCA1 that people have a risk-reducing surgery no later than age 40. And here you can see age is around 44 for BRCA2, 46, so on and so forth. And so they either wait a long time or they don't have the surgery at all. And, that's kind of like our fault, not like but like the big our, because we still know very little about ovarian function and how that changes as women age. And it's a very important endocrine organ, and very little research has been done on that. And as I mentioned before, we're not doing a good job of prescribing hormone replacement therapy to young women who are thrown into surgical menopause when they have their ovaries removed for ovarian cancer prevention. So that's why, some of the discovery that's happened over the last couple of decades, I'm like obsessed with, because I take care of these people. I have to counsel them about this. I see how fearful they are. Many of them have buried their own mothers, their sisters, and yet they have tremendous reservations about having risk-reducing surgery. I mean, if that doesn't tell you anything, I don't know what does. So, when this discovery happened in the early 2000s, and people were removing ovaries, right? You remember that diagram I maybe showed at the beginning, is that the tube and the ovary are frenemies. They're always together, right? They share a blood supply. It doesn't make sense to keep the fallopian tube around if you're taking the ovary out. And so when the ovaries are removed, the fallopian tube is removed as well. And so in the early 2000s, when this happened, and talking to people like Jürgen Peek and who are really involved in this, they would say, well, yeah, we would take the ovary out and we would look at the tube maybe for a hot minute, and then we would throw it in the trash. And then we would spend a lot of time looking at the ovary under the microscope, hoping to find some inkling of precancerous change so we could understand where the heck this cancer that never really even looked like it comes from the ovary is coming from. And then one day, Jürgen Peak, other people at MGH, Chris Crum, Ronnie Drabkin, people at Johns Hopkins, a number of other people around the world happened to look at the fallopian tube. And that really changed everything, because all of that, the precancers that people had expected to find in the ovary, we then found in the fallopian tube. And this was like a tremendous light bulb moment, because it really explained so many things that just drove everybody crazy for so long. And so, when I give this lecture, a common question that people ask is like, well, what is it about the fallopian tube, that makes sense, this alternative hypothesis? And the way I think about it is that this poor fallopian tube is sitting between two all-out wars, every month, right? So every month the ovary explodes on it, right, like a supernova star birth type explosion, and causes a bunch of damage and fallout in the end of the fallopian tube. And then, oh, but wait, 2 weeks later, just maybe when the fallopian tube is sort of getting its act together and repairing some DNA and whatnot, then a woman has her period. And a lot of, I'm not sure if people are aware of this, but a lot of that blood and even endometrium, instead of always coming out the vagina, a good part of that actually comes out, spills out the end of the fallopian tube into the cul-de-sac, the most dependent part of the pelvis, and the tubes just dangle in there and marinate in there and have further DNA damage and develop a tremendous burden of gene mutations, particularly in tumor suppressor genes like P53, P10, so on and so forth. And this happens over decades, right? From the time of menarche, which on average is age 12, to the time of menopause, which on average in the US now is 52. And as you guys probably know, that time span, as we evolve as humans, is getting longer and longer. Girls are going through menarche earlier now, and menopause is occurring a bit later. So all the more time for this mutational burden to evolve in the fallopian tube. And so, knowing that, knowing that this disease comes from the fallopian tube as opposed to the ovary really helps people understand, the way that this cancer spreads that is so different than any other solid tumor. I mean, this is not like a pancreatic cancer or a breast cancer or prostate cancer where you have like a solid ball of tumor growing in an organ and you can do imaging and find that, or maybe look in the blood and find some fragments there because the tumor's been hanging out there not causing too much of a problem for a long time. This is a picture, literally from the operating room here, of a fallopian tube, right? And what does it look like? It kind of looks like a paintbrush. And the way that I describe this to patients is that, this sort of whole problem is that imagine you are going to work in the morning, right? And you have your big pocketbook. And there's a wet paintbrush sitting there on the counter, and you're cleaning up, and you take that paintbrush and you put it in your purse, and you walk around all day with this paintbrush in your purse. And you maybe walk through a CT scanner, right? And the CT scanner is like, well, okay, it looks like maybe you have a paintbrush in your purse, but you have a pen and some pennies or whatever else. And maybe someone puts an ultrasound on your purse and they don't even see hardly anything, right? But at the end of the day, when you get home and you open up your purse, what do you find? You find paint all over everything. And it's so much over everything that you just basically want to throw your purse out, because how are you going to fix that? And if you were to, it would take, 12 hours, 14 hours? That's what an ovarian cancer debulking is like. You're there a long freaking time cleaning all that paint out. And so these tiny little precancers, cancers that start on this end of the paintbrush just slough off. They move all around the abdomen. They, form these little tumors that coat everything. And that occurs in the earliest moments of, we think, this cancer's life cycle, right? Before you could have imaging, before you have symptoms, before a blood test could detect anything in the blood. And so it's hugely problematic. And there's no imaging modalities that we routinely use in medicine that can see a fallopian tube, let alone like a teeny little, 1 micrometer size focus of cancer there. And there's, probably many reasons for that, but one is that no one really took the time to develop any, because the fallopian tube really was not of any clinical, medical, scientific significance to people. And thankfully that's changing. So going back to the story of how this all went down, between this period of 2001 and 2015, then there was a lot of research that was amassed to support this unifying theory of the fallopian tube origin of ovarian cancer. A lot, right? So there was genomic data, molecular data, things that I don't even know about. You guys probably know better than me. But there was like some really interesting stuff that even people like me thought was really kind of fascinating, right? Like this study here in 2012, which basically had a mouse model that had a knockout of 2 important tumor suppressors, one of which is P10, which is a tumor suppressor that is lost in maybe upwards of 40% of high-grade serous cancers. And what's interesting about this model is that in these mice, if you take out the ovaries, they still get ovarian cancer. But if you take out the fallopian tubes, they don't. So they're like, okay, well, this is like good proof that this likely comes from the fallopian tube. And then there were these large epidemiologic studies from the United States, Denmark, Sweden, others, that basically showed that large populations of people who had their fallopian tubes removed had a much lower risk of developing ovarian cancer, even though they still had their ovaries. So, maybe like a 42 to 65% decreased risk. And so the Canadians in British Columbia were really interested in this. And those people were like David Huntsman and Gillian Hanley and Diane Miller. And they started a public health campaign in British Columbia in 2008, 2010, where they committed to creating educational materials about the fact that a large number of ovarian cancers, certainly the most deadly common types, come from the fallopian tube, and that women should consider having their fallopian tubes removed if they're having a hysterectomy, or if they're interested in a tubal ligation, then having the fallopian tubes removed instead of having a tubal ligation. And so when this project started in British Columbia, and Diane Miller was doing a ton of education about this, the rates of something like that were very low. Most everybody was having a tubal ligation, and if you had a hysterectomy, your fallopian tubes were left inside next to the ovaries. But over the time that this campaign happened, from 2008 to 2019, so 11 years, things really changed. So now 82% of women have their tubes removed instead of having a tubal ligation, and 75% or more of people have them taken out at the time of hysterectomy. And so again, this has been going on since 2008, and Jillian really has started to take a look at what the impact of this practice change or intervention has been on the incidence of ovarian cancer in general, and specifically related to high-grade serous cancers and other histologies. And so these data she presented, it's been about a year ago or so. This was from follow-up through end of 2019, and you can see they have pretty large cohorts, a cohort of 44,000 people who have either a hysterectomy and keep their fallopian tubes, or have a tubal ligation and instead of having the tubes removed, versus about 36,000 people who have had their tubes out at the time of OBGYN surgery. And what you can see is at the time that she presented these data, there were 25 ovarian cancers in the group of people who have fallopian tubes, and only 6 in the cohort where fallopian tubes were removed for those women. And serous is represented by the orange here, and there's 20 serous cancers in the situation where people kept their tubes, and only 1 in the cohort where fallopian tubes were removed. And she has since updated these data and actually presented them a couple weeks ago at an education forum that we did in Seattle. And this number is now up to, I believe, 31 serous cancers and 6 serous cancers in the salpingectomy cohort. And importantly, at that meeting, she presented the hazards ratio. And that is a really big deal from an epidemiologic standpoint, and we've been waiting on that for some time for them to have enough statistical power to do that. And for those of you who know about hazard ratios, the hazard ratio is 0.22, which means that removing the fallopian tubes is associated with about an 80% risk reduction in someone's lifetime of developing ovarian cancer. And so this is like a real game-changing discovery, right? Especially because of what we were talking about in terms of what the ovary does versus what the fallopian tube does. So, we now know that the most common and deadly types of ovarian cancer, around the order of 80%, actually don't come from the ovary, that's more science fiction, and that they most likely come from the fallopian tube. And that removing the fallopian tube confers, this degree of protection against developing ovarian cancer. And that's super exciting because the fallopian tube, well, it doesn't really do anything that we know of once their involvement in fertility and family planning is not needed, whereas the ovary, makes hormones probably for a long time, even after menopause. And so now we have, the old dogma, and this is the old dogma where, we had ovarian cancer and it was epithelial, sort of coming from the surface of the ovary, versus there are these non-epithelial types that come from the stroma or the germ cell of the ovary. And in epithelial, you had, these histologies, and, maybe about 10% are these non-epithelial types. But now we have maybe only low-grade serous cancers and these non-epithelial types, so it's about 17% that are true ovarian cancer. So there still are some ovarian cancers out there. And then we have some that either directly or indirectly come from the fallopian tube. These are actually probably are related to endometrium from the uterus that got out into the pelvis and peritoneal cavity via the fallopian tube. We have no idea where this comes from. So 90% of the 90% of what we once called ovarian cancer is attributed to the fallopian tube, so sort of like ovarian cancer maybe is a bit of a misnomer. And so, so when we think about the populations of people out there, especially when we think about genetic risk versus people who don't have a genetic risk of ovarian cancer, it's really important discovery because when we think about or know about people who get ovarian cancer, only a small fraction of the people who get ovarian cancer, about 20%, have genetic risk. Really, this cancer, I should be calling it tubal cancer by now so I don't confuse you guys, but most everybody with this ovarian cancer are seemingly average risk people, just like all of us out there walking around in the world, down the street, so on and so forth, and don't have genetic risk. And as I pointed out before, many people who have genetic risk don't have testing, so they don't know they have risk, and we can't make any recommendations for them. And so then that sort of gives way to thinking about how do we think about this in clinical medicine? And this is how I think about it now, even in my own clinic. So the number one criteria for having a risk reduction for ovarian cancer that's related to the fallopian tubes is that you don't need them anymore for fertility. And that could mean any number of things, like you're done having kids, you never wanted to have kids, you couldn't have kids, you want to have kids but you want to use IVF or you want to adopt or who knows, any number of things that women do these days. And so that is exciting because we have so many things that make the fallopian tube not necessary. And you have sort of 3 different groups of women. You have people who are high risk, which we say now is people who have greater than a 5% lifetime risk of developing ovarian cancer. So certainly BRCA falls here, right? 20 to 40% lifetime risk, but other gene mutations are here. And there's this new strategy that's developed for high-risk women, right? These women that have been so afraid of having risk-reducing surgery and not having that procedure done. they can have their tubes out very early and then maybe wait to have their ovaries out until closer to the natural age of menopause, or maybe never. We don't know, but this strategy is being studied on a large international trial called TUBA-WISP, which is a trial that's enrolling about 3,000 patients. They've enrolled 2,000 so far. I just heard an update a couple weeks ago. There's not been any, concerning safety signals related to this. And this is really exciting because ultimately we'll probably have 3 cohorts of women on the TUBA-WISP. People who have the old strategy of having tubes and ovaries out at the recommended or around the recommended age, people who have this new paradigm, tubes out early, ovaries out later, and then probably a third by default, people who get their tubes out and never come back and get the ovaries out. Then you have moderate risk people, so people who, I take care of a lot of these women, people who have had a family member, first degree typically, or even second degree, who had ovarian cancer, but the genetic testing is negative, and they want to do something. And so this is a great option for them, and this is a real interesting area of research as well. And then average risk, so like everybody else. So, the vast majority of people, right, who have a 1 to 2% lifetime risk of developing ovarian cancer, also have the option of having their tubes out. And there are ways to do this in a less risky, more, beneficial way. We'll talk about that in a second. But importantly, this is sort of tagged at around the age of 50, because there's some newer data out of Denmark that indicates that risk reduction with respect to ovarian cancer seems to trickle off when you have your fallopian tubes out as a risk reduction strategy after the age of 50. We don't really have any other age thresholding from Denmark yet. 50 to what? Or like, what about 55? Is that okay? We just don't know. But I think it's important, just from a, even scientific and clinical perspective to note that. So I was just saying, like, for the people who are average risk, have this 1 to 2% lifetime risk of developing ovarian cancer, having their fallopian tubes removed may be something we should think about, right? We have a disease we can't screen for, a disease that we have very limited treatment options for, what about thinking about doing fallopian tube removal at the time of other surgeries, right? The Canadians have been interested in this since 2008, right? Removing fallopian tubes at the time of hysterectomy, taking them out instead of tying them. And that is known as opportunistic salpingectomy. So the idea of taking the opportunity to take the fallopian tubes out when someone's already having surgery on their abdomen, they're having anesthesia anyways, they've already incurred the risk of that primary surgery and the cost of that primary surgery, right? So all that equipment, all that OR time, anesthesia, everything is assigned to the primary procedure. So that's kind of cool. And so that has been of increasing interest in the United States. We're about 10 years behind Canada, unfortunately. And our college, the American College of Obstetrics and Gynecology, and SGO, put out recommendations recommending OS, which is opportunistic salpingectomy, in 2013 to 2015. And the adoption of opportunistic salpingectomy by the field of OBGYN has really increased since that time. And that's really exciting. And the areas where there is the most opportunity really is in the space of OBGYN, right? And so, right now there's over 1 million tubal ligations that are done in our country every year. Sorry, this doesn't work that great. And about half a million hysterectomies. But this number is going down. And these two opportunities are much higher than these other ones, right? Non-GYN surgeries like, getting your gallbladder out, having your appendix out, hernia repairs, colon surgery. Those together maybe account for about 500,000 opportunities in the US annually. There's been some interesting modeling around this. And so, one of the modeling studies showed that if women could universally choose salpingectomy instead of a tubal ligation, or when they have a hysterectomy, we would prevent almost 2,000 deaths per year from ovarian cancer and save almost $500,000 healthcare dollars annually. And that's really impressive. And we sort of talked briefly about the addition of non-OBGYN surgeries. This is also projected to be cost-effective and even cost-saving, and we just did a cost-effectiveness analysis with breakthrough cancer related to this, and so that's really exciting. But it's also life-saving, right? So yes, it saves money, but it also saves people's lives. And it's feasible. It can be done. And so this was really the first and only trial published to date of fallopian tube removal at the time of non-GYN surgery, was by Carl Tomasino, who helps head the international task force with me. And Carl basically showed that it's acceptable to women to be approached about having fallopian tube removal at the time that they're going in for gallbladder removal. And it's feasible and can be accomplished in 93+% of the time. It takes about 13 minutes. And so that was really exciting. So, everybody is working in this space now, and hopefully we'll start to see some more data. And then the last, 10 minutes or so, I just had wanted to talk to you about, this is super exciting. And, but there's some really important considerations. And it's not just like we can wake up tomorrow and have this, be a thing. So, I don't know what it was, 2021 maybe. Kara Long, who is my best friend and co-investigator at Sloan Kettering, and I, we're talking on the phone. I was like, hey, maybe we should really do something related to this. And she was like, well, I don't know. That's like a big project. I was like, we could, figure out how to expand opportunistic self-injectomy outside of OBGYN and unsilo it and bring it to general surgery and all that. And so fortunately, she agreed maybe to work with me on this. And fortunately, Breakthrough Cancer agreed to fund the early years of this project, which was incredibly kind and generous, and we are forever grateful for that. And our idea at the time was, okay, well, we're going to take sort of this next, or end of this second disruptive cycle where we're going to, move things, transform things from OBGYN into the general surgery space. And we made one key assumption that was incorrect, and it was that we had achieved standard of care in OBGYN. But in fact, we were still in the adoption phase in OBGYN, and we had not developed a standard of care that most of us would be proud of in medicine. And so, so we were like, well, this then really matters to get this right in OBGYN, right? For some obvious and not so obvious reasons, right? I just showed you this, right? The vast majority of opportunities are in the space of OBGYN, right? The lion's share of opportunity, replacing tubal ligation with the salpingectomy, taking tubes out at the time of hysterectomy. And we've seen a really steep rise in the number of women who are interested in having permanent contraception, tubal ligation, since the Dobbs decision, since the constitutional right to abortion was overturned. But the status quo in OBGYN of opportunistic salpingectomy really has not been that great. And there's been a few people that have started to look at this, and what we see is that really it's pretty much white people who are getting a salpingectomy instead of a tubal ligation. And so that, non-Hispanic white women are more likely than any other racial or ethnic group to have a salpingectomy instead of a tubal ligation. So, and that's where the most opportunity is. And so when I started working on this, I was sort of horrified by that. And I thought, well, I work at Johns Hopkins, and that's an ivory tower, and we do everything how it's supposed to be done and all their latest things, and et cetera, et cetera. And so one of the first projects I asked our BTC postdoc to do was to go to the billing people and get me all the billing data on tubal ligation and salpingectomy, and let's see what's going on. And she brought that back to me, and it was very confusing because it looked like everybody was having a tubal ligation still. And so I yelled at a bunch of people, and they were like, no, we're all doing salpingectomy. And I was like, okay. So then we just did this massive chart audit of like hundreds and hundreds of charts. And it actually, I had to apologize. We were doing a lot of salpingectomies. Almost 90% of our patients were getting salpingectomies done. But it was concerning in that there were some factors that were associated with some populations of people in the ivory tower getting tubal ligations instead of salpingectomies. And primarily, they were our patients who have Medicaid and Medicare. And so there are a number of reasons that this is the case, but one of the main reasons, one of the foundational things for why these disparities, inequities exist is outdated healthcare policy. And this is a great example of that. This chart shows you differences in state Medicaid coverage of permanent contraception according to what state you live in. So there are some states that are like, we got you. We're gonna cover a salpingectomy for you if you have Medicaid, Medicare insurance. There are some states, and I live in one of them, Maryland, that's like, nope, we haven't updated this yet. Sorry, come back next year. And then there's a whole bunch of them where we actually have no idea what's going on, and Massachusetts is one of those. And so this is really the bedrock of a lot of that disparity. But so say you were like, well, let's just not call it a tubal ligation. We'll just give it a different billing code and we'll submit it with a billing code for prevention. Surely there must be billing codes for that. And so, when people send a code into insurance to get it reimbursed, they have to tell the payer what was done, and these are the two codes that exist for salpingectomy, and it has to go along with what's called an ICD-10 code, and that tells the payer why something was done. And so we were like, in the early years of this project, we were like, oh, yes, there is a code. So we could just educate people about using this code. But then when you go read the fine print, that code is supposed to be used only for people who have a genetic susceptibility or family history. It doesn't cover everybody, so just that small portion of patients. And so we were like, oh gosh, there actually is no ICD-10 code for salpingectomy for ovarian cancer prevention when your only risk factor is being a human who has fallopian tubes. And so this is hugely problematic, right? Because we see this play out in our data when I first looked at it and had to yell at people, right? Which is that people in the ivory towers or in everywhere, OBGYNs, right? We want to take good care of our patients. We want to provide them we want to protect them from the things that we see killing them. So we do salpingectomies for them, but we bill them as tubal ligations. If you have somebody who's older, right? Say you have somebody who's, 53 or whatever, and they want to have their tubes out at the time of a cholecystectomy, there's no way to bill for that. So what happens is that procedure just gets assigned the diagnosis code that's associated with the primary procedure, so like cholecystitis. So then it looks like the tubes came out to treat the gallbladder disease. And so this is just hugely problematic. This is literally the real world of the ivory tower. And it's also problematic in that when we started this project, there were zero educational materials about the role of the fallopian tube in ovarian cancer prevention and salpingectomy. And we did this massive audit across all the different places where our patients go for education materials. I would go to clinic and we would have this poster hanging on the wall, and I'm like, well, where is salpingectomy in there, right? And we would read on ACOG, and it would say just this. This is all that's written. It says, well, if you're high risk, maybe you should have some risk reducing surgery, and the timing of that should depend upon your desire to have children in the future. If you're at average risk for ovarian cancer and already having abdominal surgery for another reason, you might consider surgery to remove the fallopian tubes. And that's pretty much it. And so, this is really not so great, because when you think about education, not having good education materials is really one of the reasons that things like forced and coerced sterilization happened, only several decades ago. And it's also the reason why, speaking of that, we have forms like this, and anybody who's an OBGYN is probably familiar with this form. This is a form that Medicaid and Medicare patients have to sign 30 days before they have a hysterectomy or have a tubal ligation. Otherwise, In many places, they can't get the procedure done. So God forbid you have your baby early and you don't have this form signed, or any million other reasons. You're late to prenatal care or whatever. It's been a huge barrier to women getting the care that they need. And then on social media, we sort of see this play out in the fact that there's no education materials. People saying, there's like millions of these. This is just one of them. This is what I do late at night when I can't sleep. I go and do social listening. It says, good morning, my first time posting. I'm guessing my last. I went to the doctor to find out exactly what method they used to tie my tubes, only to find out they were removed. So this person, wasn't maybe even counseled about the fact that they were having a salpingectomy instead of a tubal ligation. And this person's like, oh, you can still have IVF, et cetera, et cetera. And then doctors, right, highlight the fact that in order to really, make salpingectomy for ovarian cancer prevention a thing, we need coordination, counseling, and we have to fix billing issues. So, while we have this extraordinary advantage of being able to reduce the threat of ovarian cancer with things like salpingectomy, adoption of that intervention in my own field, my field of OBGYN, has really occurred without the necessary steps to establish a standard of care that would make people be proud of. And so that is what we have spent a tremendous amount of time over the last 3 years, going on 4 years, with the team at Breakthrough Cancer working together on, which is what does it take to transform practice into a standard of care that one can be proud of, right? It takes science, infrastructure, public health campaign, and more science. And we have to do all of these things, right? It takes a massive amount of people, and this is what the team looks like compared to where we started at the beginning. And it takes smart people, engineers, scientists, people who really are able to work with and talk to surgeons, because I feel like you guys are surgeons. You just maybe made one different decision than we did when we were 18 or something. Right, so I've been at the CDC for a couple of years, getting all the coding fixed for this so that we actually have a code for opportunistic salpingectomy so that it doesn't tag along with codes for cholecystitis or whatever. We have a code for STIC, the immediate precursor to high-grade serous cancer. How about a code for a family history of malignant neoplasm of the fallopian tubes? That seems like a code one might need. But that doesn't get you change, right? Just getting coding, right? So you got code, great. In order to really change things, you have to have lawyers. You have to have a lot of lawyers. And so we do, thankfully now, and you have to have lobbyists, and you have to have, this is Senator Nick Charles, who's working with us in Maryland to make change in Maryland, and really to establish state and federal policy that's better aligned with science and best practice of salpingectomy for ovarian cancer prevention. I told you we did a big cost analysis, but this is really what the numbers are, okay? So these are numbers sourced right out of our Medicaid billing data at the ivory tower of the Johns Hopkins, and you can see, this is the most economical situation to do it in, right? So patients having their last baby, it's the index of delivery, C-section, or they've had a vaginal delivery and they're still in the hospital. Could be $0 as long as you don't use some fancy equipment. At hysterectomy done opportunistically, or some other surgery opportunistically, just the cost of someone like me going in and doing it. But if we could teach general surgeons or urologists to do this number would go to zero, or close to zero. And this is the most expensive scenario, is if you decide to do a salpingectomy instead of a tubal ligation for permanent contraception. But I'm sure that'll change once CMS realizes that it is expensive. But that is compared to over $1 million that it takes to treat a single person with ovarian cancer, and that person almost always still dies of their disease. So, we are developing a ton of education materials and have over the past couple of years, and this is our Outsmart Ovarian Cancer website, which is intended to be this trusted site of multimedia learning materials for patients, doctors, surgeons, everyone to go to and learn about this scientific discovery, the people that are involved, where did this come from, what still needs to be done, how do you consent somebody for it, what should a patient watch if they want to learn about it, what if I have a Spanish-speaking patient? And this has really been, over the last year, really iterated and improved due to a lot of the community outreach and engagement work that we have done with the support of Breakthrough Cancer. And this is what some of the resources look like. Importantly, we have surgeon instructional films, which is filling a huge unmet need. We've also been out in the world, trying to create dialogue about this in the places that doctors, scientists, everybody goes, like JAMA and Scientific America. Marty McCary wrote this book called Blind Spots, which is now the #1 best-selling book on Amazon, which has a whole chapter on this discovery now, and he interviewed Jillian and I and everybody about this. It's been on Jeopardy. My mom recorded this, and he gets it right. And we are creating some really novel education materials with our Art as Applied to Medicine department at Hopkins, which is a really unique department of artists who come to the operating room to learn about these areas that we need help explaining as clinicians and surgeons and so on and so forth. And so this is Abby Rump, and she has been working with me over this past year. Remember that when I was like so annoyed about this? So she's updated this. This is that classic, this is your birth control options. And it tells you how effective they are in terms of pregnancy prevention, and it also tells you how effective they are in terms of decreasing your risk of ovarian cancer. And so we really need that, and this is from the documentary that we were recently filming. And we have to have a clinical trial, right? Because we have to make the obvious official since forever. And I'm not gonna talk too much about this because I wanna answer some questions, but in our hands, especially with education materials, 72% of women find this acceptable at non-GYN surgery. They learn a lot with the educational module. It's empowering them to make decisions about their body. And these are 11 of the patients who have undergone opportunistic salpingectomy at colon surgery at Sloan Kettering. And amazingly, I think this was like a gift from God, being like, just keep going. We intercepted already 1 high-grade serous cancer in the left fallopian tube in someone who is having colon surgery. So that's like really exciting. But there's this problem, that people who have their tubes removed still can get high-grade serous cancer. Why is this? Because we have an Achilles heel, that when a tube comes out, we're only really able to look at 1% of it. And so that's why we have this with you guys here at MIT, where we have the first ever of its kind IRB. Thankfully, the Hopkins is supporting, where I take someone's fallopian tubes out in the operating room after they sign consent to participate in the research protocol, which literally everybody does because they get it. We send them in transplant media overnight on a plane up here to Neil and Angie and everybody in the Belcher lab. It goes through this fancy molecular imaging called OvaSeq, but I think we should rename it, Neil. Anyways, and it's a molecular imaging. It's designed to find these tiny little abnormal foci on the whole organ, the whole fallopian tube. Neil tattoos them. He sends it back to us at Hopkins. And Russell Vang, who really has defined this entity, the precancers that give rise to high-grade serous cancer, looks at those little tattoos to see what's going on there, and also benchmarks it to standard histopathology, which again only looks at about 1% of the fallopian tube. And that's that. Oh, I will answer.
Thank you, Becky. That was really inspiring. So, questions from the audience, and while they're thinking, I guess I have a question I'd like to ask, and that is, it's striking looking at the BC cohort that yes, you reduce high-risk serous and the overall numbers are less, but if I did the math right, looking at that, you've actually done nothing to the endometrioid and the clear cells, or at least the absolute number. I mean, it's tiny numbers, so who knows what that means?
Well,
but does this mean that that's already happened before, or like, how do you think about that?
I think that these are really good questions, and Jillian and I have become, pretty close over this over the last couple of years, and I asked her this, and so it's probably related to a number of things. One is that in any of these studies that you look at, you have to make sure that the two cohorts are matched, right, in terms of other confounders for development of tubo-ovarian cancer, right, of which there's a number of histologies that endometrioid and clear cell type probably come from endometrium that's gotten out ectopically into the peritoneal cavity. And so you have to make sure that they have the same rates of endometriosis.
I was going to say, if it's endometriosis, that could happen before.
Yeah. So the good news is that Jillian's study is the only study where we actually have data on the confounders between the two groups, and they are equivalent. So you can't explain it with that. But some of the older studies that I showed you from like the US, Denmark, Sweden, these sort of bigger epidemiologic studies, it's very hard to control for confounders in those studies, so you have to sort of be careful how you interpret those data. The other thing is that remember that in the OS cohort, the cohort of people who have their tubes removed, a large number of those people have them removed as permanent contraception. So they still have their uterus in place, right, as opposed to a hysterectomy. And so I'm always like, Jillian, how does it compare between, can you do a subset analysis of like people who had hysterectomy versus, tubes out compared to tubal ligation? She always rolls her eyes at me. But we're very interested in getting these data in the United States. Many of you guys know I'm like obsessed with this and trying to find like a big data source. But it's hard in the US, right? Because we don't have a nationalized healthcare system. And we have all of these claims data where people at Johns Hopkins have been doing salpingectomy but billing it as a tubal ligation. So we actually, in the United States, unless we are able to link claims data with some genius AI technique that can look into a medical record, peer into a path report, an op note, we are not going to be able to get this data from the United States. But I think there is a way to do it, and so we're trying to get it, and that way we can validate hers.
Yeah, it's both the challenge and opportunity of using the medical record and AI approaches.
Yeah.
Other questions, Neil?
Thank you for the great, inspiring talk, Becky. I have a question in terms of the more widespread adoption of opportunistic salpingectomy. You provided a compelling case for the cost savings over treating a person with ovarian cancer, about how more cost-effective it is for this procedure. But once you get out of an ivory tower like Hopkins, could you perhaps comment on the acceptance of this procedure for general surgeons like urologists or other people in terms of the added surgical time and resources needed?
I think that's a great question. So Neil's asking, it's compelling when you look at it from the standpoint of saving money and lives, but is it that compelling in terms of will people actually do it? Do we think we actually can achieve radical collaboration with non-GYN surgeons? And I mean, we've been working on this and talking about this, and we're doing this feasibility trial at Hopkins and Sloan Kettering and MD Anderson, recognizing that those are all sort of crown jewels of medicine. But I give some version of this talk at a number of places in the U.S., and people are very interested in this. I mean, there are whole hospital systems right now, like in Georgia and Connecticut, and so that want to implement this and want to have implementation package. I mean, they are like, give us the consents, give us the videos on how to do this, and so we're now challenged with that there's an increasing interest and demand, and how do we? I mean, I'm not an implementation scientist, but how do we create that for people and make sure it's done safely and track it and make people bill it correctly?
Okay, we'll do one more question.
Thank you for an excellent talk. I'm interested in the cohorts of patients you now have with the salpingectomy. Have you looked at incidence of endometriosis or distant endometriosis, given that one of the theories of endometriosis initiation is through retrograde menstruation?
So in Jillian's study, that Canadian study, they compare the groups in terms of endometriosis. But to your point, there's endometriosis, and then there's that infiltrative, terrible, this endometriosis is going to undergo malignant transformation endometriosis. And if you're a clinician or a surgeon, you operate on these people, you know what that is when you see it. It's terrible. And so in that nuanced of a way, I don't think that they have that information. But I do think that, for instance, like there's a lot of research by a person named Jim Seegers at Hopkins that's really interested in characterizing that deep infiltrative endometriosis and like what's the gene mutation burden there in terms of like ARID1A mutations and whatnot. It would be interesting to look at it, with respect to incidence of non-serous fallopian tube cancer or uterus cancer. I don't know what it is anymore, but anyways.
All right, well, thank you so much, Becky, for coming. I just want to editorialize, say in closing that, in my personal opinion, I think this is some of the most important work that I've heard about in some time in terms of the potential to save lives. So I think you guys really made a good decision to show up today and get to hear about it early. I also want to, again, thank our colleagues who are joining us from MGH. It's wonderful to have you guys here with us today as well. And one more thank to Josh, who's here, but actually the entire Lippard family and friends for making this lecture possible. Thanks again.